So let's dive into loss and grief. So first, what is loss? So loss is an inevitable part of life and can have profound physical, emotional, and psychological effects. Nurses are going to play a really key role in assessing, supporting, and guiding patients and families through this loss. So first, there's different types of loss. There's actual and perceived. Actual loss occurs when a person can no longer feel, hear, see, or know a person or object. So examples of this is like a death of a loved one, an amputation, a loss of a body part or function. And then you have perceived loss. So this is felt by the person experiencing it, but it's less obvious to others. So this is like social rejection, loss of self-esteem, loss of independence, and infertility. So there's multiple different types as well. So like we talked about infertility, that's the inability to conceive a child. An amputation or disability, that's loss of a body part or function. Sometimes we have that loss and it's an unwanted disease, diagnosis, or chronic illness, so diabetes, cancer. And then impending death, that's the anticipatory grief of a terminal illness. Overall, individuals are going to respond differently depending on their personality and coping skills, past experiences with loss, their support systems, their cultural and spiritual beliefs. Reactions really can include all types of emotions: sadness, anger, anxiety, denial, or withdrawal. Death is the ultimate loss. So death represents permanent, irreversible loss, and it triggers a range of grief responses in patients, clients, their families, caregivers. So as nurses, we need to make sure that we are providing emotional support and active listening, assessing those grief reactions, and then guiding through end-of-life planning, rituals, and bereavement resources. So grief is actually the complex personal experience. It's each person's response is going to be unique in how they grieve. It's going to be influenced by personality, culture, coping mechanisms, and the type of loss being experienced. Nurses, we really play a key role in assessing, supporting, and guiding patients and families through this grief and potentially bereavement. So there are going to be responses to loss that are more complex. It can include emotional, cognitive, physical, social, and spiritual reactions. And those are all things that we do need to watch for. You have different types of grief. You have anticipatory, complicated, and cumulative grief. So anticipatory grief is grief experienced before an impending loss. So for instance, like a terminal illness. Complicated grief is prolonged or intense grief that interferes with normal functioning. And then you have your cumulative grief. That occurs when multiple losses happen simultaneous or in succession. You also have mourning. So mourning refers to all outward expressions of grief and the behaviors taken to cope with loss. So crying, attending rituals, seeking comfort or support, creating memorials. They're typically going to be culturally influenced. Rituals and expressions really are going to vary widely during mourning. Bereavement refers specifically to the period of sadness following a significant loss due to death. It involves both emotional and behavioral responses to that loss. So nursing cares that we can do during bereavement is provide emotional support and active listening, encourage healthy coping strategies, assess for complicated or prolonged grief, and provide resources for counseling or support groups. So then there are several different theories of grief and mourning. As we said, it's a complex individual process. So that explains why we have so many different theories. So you have the stages of dying, that is more focused on terminally ill patients. And then it was later applied to like generalized grief. This is where you have your 5 stages, which we'll talk about next. Then you have attachment theory. So this is where grief is influenced by the strength and nature of the attachment to the lost person. So phases with this are like a numbness shock, a yearning or searching, disorganized, disrepair, and then reorganization and recovery. You have your grief task models. This views grieving as a series of tasks rather than stages. So first is acceptance of the reality of the loss, process the pain of grief, adjust to a world without the deceased, and then finding an encouraging connection while moving on. Then you have Rando's R, process model, and that is where grief is a series of interconnected processes. So recognizing the loss, reacting emotionally, recollecting and re-experience the relationship, relinquish old attachments, readjust to life without the deceased, and reinvent in new relationships or activities. And then lastly, you have the dual process model. This is when grief involves oscillating between two types of stressors. So you have loss-oriented and restoration-oriented. Loss-oriented is confronting and processing the grief. So that's crying, remembering that individual, whereas restoration orientation is managing daily life and adapting to changes. So, what's changed at work, responsibilities since this loss. And here you have those stages of grief that we talked about in the last slide. So you have the 5 stages. So you have first denial, that's the refusal or inability to accept the reality of the loss. Typical behaviors may be shock, numbness, disbelief, or avoidance. And as nurses, we just need to provide gentle support and allow that patient or family member time to process and avoid forcing any acknowledgement. Second, you have anger. So this is frustration and resentment directed at themselves, others, or the situation as a whole. So behavioral examples, maybe irritability, blaming, questioning why me. And then as a nurse, we need to make sure that we empathetically listen, validate their feelings, maintain safety, and provide reassurance. The third one is bargaining. So this is attempting to negotiate or make deals to change the outcome. These are going to, this is going to exhibit by maybe the individual saying, if only I do this, maybe it won't happen. So you're trying to bargain if things were different. As a nurse, we need to support expressions of hope while gently encouraging the realistic understanding of what has occurred. Depression, that's that profound sadness and mourning as reality is really starting to set in. Behavioral examples are going to be that the individual may be more withdrawn, crying, they may have a decreased appetite, fatigue, and hopelessness. And for us as the nurse, we need to offer our presence, encourage discussions of their feelings, assess for complicated depression, and promote those support services. And then your final stage, or stage 5, is acceptance. That's really coming to terms with the reality of the loss. So this is when they start to plan for the future, they're becoming a little bit more emotionally stable, and then they have a renewed interest in life again. And as the nurse, we can support coping strategies or provide good coping strategies, encourage life adaptation, and then validate memories and any connections. So what are some factors that affect loss or influence loss and grief? So the experience and responses to loss are highly individualized. Everyone's going to be different. There's going to be several factors that influence how a person or individual perceives, reacts to, and copes with their loss. So first is just human development. Age and developmental stage is going to affect the understanding and the response to loss. Children may not understand the permanence of it, and their grief may be expressed through behavior. Adolescents, they're already struggling with identity and independence, and so this may cause more of a struggle, and then they're going to need more peer support. Adults may face multiple types of losses, whether that's career, health, or relationships. And then older adults, they just may experience cumulative loss, like kind of one right after another with friends, maybe their own mobility and family. Personal relationships, so the strength and nature of attachments influence that grief intensity. So the loss of a spouse, child, or close friend may trigger more profound grief. Then the nature of the loss, was it sudden or unexpected? Or was it anticipated? Was it expected or was it ambiguous? So sudden loss typically can cause shock and complicated grief, and anticipated loss allows some preparation, whereas ambiguous loss, like a missing person, complicates that grieving. Some coping strategies. Effective coping is seeking support, problem solving is spiritual practices, whereas ineffective coping is when you avoid, you have a patient maybe utilizing some substances, they're in denial and isolation. Socioeconomic status can play a factor in this. Limited resources can complicate grief. Think about like the cost of a funeral, loss of income, healthcare access. those financial stressors may really intensify that emotional distress. Some cultures are going to influence loss and grief. Cultural beliefs and practices are really going to help shape how grief is going to be expressed. So, cultural norms influence the rituals, mourning periods, and supportive systems. So, grief and loss affects patients, like we said, physically, emotionally, cognitively, socially, and spiritually. So, emotionally, we may see sadness, tearfulness, or crying, anger, irritability, resentment, anxiety, fear, guilt, difficulty accepting that loss. Cognitive and behavioral cues, we may see confusion or poor concentration. Preoccupation with the lost person or object, and then withdrawn from usual activities or social interactions. You can also see that the individual may have a change in their appetite, sleep pattern, or daily routine. Some physical or physiological cues, fatigue or low energy, sleep disturbances, weight changes, somatic complaints like a headache, stomachache, or other pain, maybe even some change in their vital signs related to that stress. Stress would cause tachycardia or elevated blood pressure. What about looking at their social and relational cues? So are they being more isolated or having a lack of communication with their friends and family? Do they have a loss of interest in work, school, or hobbies? And then what's the dependence on others for their emotional support? Nursing considerations as a whole, we want to utilize active listening and therapeutic communication to encourage expression. We want to ask open-ended questions about feelings, coping, and support systems, assess for complicated or prolonged grief that may require referral to counseling, and then monitor for risk of self-harm or depression in intense or prolonged grief. So these are just another few grief variables. And then these are some grief reactions. So grief reactions is that psychological and physical assessment skills that we can utilize to assess grief responses. So the feelings, cognitions, physical sensation, and behaviors. Do review this. So then the nursing role in the end-of-life care. End-of-life care really is going to focus on comfort, dignity, symptom management, and psychosocial support. So we want to assist in end-of-life decision-making, provide information about the prognosis and treatment options, support family and the patient themselves in advanced care planning, living wills, and DNR orders, making sure that we know the difference between palliative and hospice care, which we'll talk more on the next slide. What about therapeutic communication approaches? We want to utilize active listening, utilize open-ended questions. Silence is going to be key, and empathy. We want to encourage our patients and their family to express fears, feelings, and concerns. We also want to make sure that we avoid any false reassurance, but that we do validate feelings and support their coping. Psychosocial care, we want to assess for anxiety, depression, or maybe even the fear of death, provide support for social needs and relationships, encourage expressions of emotions and reminiscence. Then you have manage symptoms. So pain management using pharmacological or non-pharmacological interventions. If somebody's having dyspnea, nausea, agitation, and fatigue, we want to control those. And then we want to regularly assess for comfort and adjustment and adjust those interventions as needed to help make them comfortable. We want to promote dignity and self-esteem. We want to respect the patient preferences, their privacy and autonomy, encourage participation in care decisions and personal grooming as able. We want to also make sure that we have a comfortable and peaceful environment. We want to reduce the noise and maintain a calm, clean, and familiar environment. We want to adjust lighting, temperature, and bedding for comfort. Spiritual comfort and hope. We do want to assess their spiritual beliefs and practices, facilitate access to maybe a chaplain or religious support within the hospital or wherever they may be. And then we want to protect against any abandonment or isolation. Maintain presence and frequent communication with the patient and their family, encourage family involvement and visits, and provide emotional support during periods of loneliness or fear. Then you have supporting of the grieving family. We do want to provide education about expected physical and emotional changes, and then encourage that open communication, expression of feelings, and participation in care. And then ultimately, we just want to facilitate that mourning, encourage family to express their grief and share their memories, respect cultural and religious mourning practices, and then provide guidance for bereavement resources after the patient has passed. So here's a good slide about the difference between palliative and hospice care. So palliative care is going to help improve quality of life for patients with a serious illness, whereas hospice care is going to provide comfort at the end of life, typically when there's about a less than 6-month prognosis. Palliative care can begin at diagnosis and continue alongside curative treatment. Whereas hospice care is going to begin when curative treatment is no longer desired or effective. With palliative care, it's really important for us to focus on symptom management, psychosocial support, and spiritual care, whereas in hospice, the focus is going to be more on comfort, dignity, symptom relief, and support for the family and the patient. And then post-mortem care and nursing responsibilities. So after a patient's death, nurses are responsible for ensuring dignity, following legal and institutional policies, and supporting the family. So federal and state laws require healthcare institutions to have policies and procedures for postmortem events. We do need to make sure that we document and record the time of death, any interventions, any observations according to agent policy or protocol. Organ and tissue donation is going to be discussed and requested at the time of death, and family consent is obtained unless the patient is a registered donor. An autopsy, a family can consent. Family consent is typically going to be required for an autopsy unless it's mandated by law. So, for instance, if it's a suspicious or unintended death, then likely an autopsy will be done. The medical examiner will then determine the necessity in certain cases if an autopsy can be done or not. In Peoria County, if the medical examiner or the coroner believes that the case is not an autopsy needed case, the family can pay out of pocket for an autopsy if wanted. Post-mortem care, someone providing care of the body. We want to maintain dignity and respect for the decedent. Prepare the body, so we will, as nurses, clean, position, and dress according to any of our policies and procedures at the agency, and then the family request. We want to preserve any cultural and spiritual practices, so respecting the patient and family importance for those practices and letting them do those as needed if it's safe. Protect against any infection, so following those standard precautions as appropriate, and how long that patient need, before they need to leave the unit. Family support, we do want to provide families to see and touch the body if they wish of the patient that has passed. We do want to encourage mournful expression in grieving rituals. And then we also want to make sure that we provide information about funeral arrangements, support services, and bereavement services. Ultimately, the nursing priorities is ensuring legal requirements, so that we are doing as our facility has delegated, making sure we're documenting appropriately, doing the organ donation as requested by the patient or the family, and then the autopsy. We want to maintain professionalism, compassion, and respect for cultural and spiritual practices, and overall we want to support the family in their coping and grief and allowing time for closure and a farewell. If you have any questions, just let me know.